Good morning, friends. I am Dr. Shoaib Padaria from India, and my topic of discussion today is nerve damage during endovenous thermal ablation. I have no conflicts of interest. We all know that nerve damage is the most common cause of litigation. So, how often does nerve injury actually occur in clinical practice? It has been reported that saphenous nerve injury can occur in up to 37% of patients, while sural nerve injury has been reported in up to 4 to 5% of patients. The consequences of nerve injury can be varied. In most cases, it is a sensory loss to the areas which are innervated by the saphenous and the sural nerves. There is usually paresthesia and dysesthesia, which spontaneously resolves within a few months. However, if the motor nerves, such as the tibial nerve or the common peroneal nerve, is damaged, foot drop can occur, which can be permanent. Now, the common question asked is the heat which is generated during laser therapy or radiofrequency ablation, is it safe and is it responsible for the nerve injury? There was a good study done by Beal et al. And published in Phlebology 2006, in which they studied 12 patients who were treated by endovenous laser of the long saphenous vein after giving good amount of tumescent anesthesia. They placed thermocouples at 3 millimeters, 5 millimeters, and 10 millimeters away from the wall of the long saphenous vein. In the experimental model, the intravascular temperature ran up to almost 1300 degrees centigrade, which was recorded. Now you see in this illustration, in the vein itself, the temperature was about 1300 degrees centigrade. But as you go 3 millimeters away from the vein, the temperature falls to only 34.5 degrees centigrade. And if you go 10 millimeters away from the vein, the temperature is only 31.1 degrees centigrade. So the conclusion is that if you give adequate amount of tumescent anesthesia, this definitely avoids damage to the surrounding tissue, and the temperature of the thermal ablation cannot give rise to thermal injury in presence of adequate tumescent. So therefore, how does the nerve actually get injured? There are three basic mechanisms. One is needle stick injury, which occurs during cannulation of the vein. Secondly, needle stick injury, which occurs during administration of tumescent anesthesia. And finally, of course, the heat transfer during endovenous thermal ablation if you do not give adequate amount of tumescent anesthetic. What are the strategies which we can use to prevent nerve injury? The most important is knowing the anatomic position of the veins and nerves, and this helps us to determine the level of entry site into the vein. Secondly, observe the vein and the nerve very carefully by ultrasound, both during cannulation as well as during delivery of the anesthetic agent. Next, withdraw the needle immediately if the patient complains of any sharp pain. And finally, and most importantly, give good amount of tumescent anesthesia to adequately separate the nerves from the veins. Which are the important nerves which we should be worried about? One is the saphenous nerve, secondly the sural nerve, thirdly the tibial nerve, and fourthly the common peroneal. So first let us discuss saphenous neuropathy following endovenous thermal ablation. We know that in surgical stripping, the incidence of saphenous injury is seen in about 5% of patients. And it's important for us to know what is the anatomical relationship between the saphenous vein and the superficial nerve, which in this case is the saphenous nerve. In the thigh, the long saphenous vein rarely has a close relationship with the saphenous nerve. However, in the leg below the knee, the long saphenous vein frequently runs along the saphenous nerve. In the middle third of the leg, it's in almost 60% of patients. And as you go lower down in the lower third of the leg, in almost 80% of the cases, the long saphenous vein and the saphenous nerve run together. If you see this cross-sectional view, you will see that above the knee joint, the saphenous nerve and the saphenous vein lie in different compartments. But as you go below the knee, they both lie in the same compartment. And this is well seen in this picture here. As you see, below the knee joint, the saphenous nerve comes out and lies very, very close to the saphenous nerve. What is the effect of nerve injury on the saphenous nerve? When the saphenous nerve gets damaged, there has been sensory loss to the medial aspect of the calf, the medial part of the ankle, and the medial part of the foot. This was a very good study which showed the incidence of saphenous nerve injury after endovenous laser ablation. And this was an electroneuromyography study in which 34 limbs with GSV reflux were studied. And this showed that if you give good amount of tumescent anesthesia, there is no ENMG change and no saphenous nerve injury at all at 2 weeks of follow-up. And this was in the presence of good amount of tumescent anesthesia. Only 2 out of these 34 patients had mild degree of dysesthesia in the upper thigh. But what about doing thermal ablation in the lower part of the GSV, in the mid leg, lower leg around the ankle, and also in the lower part of the short saphenous vein? Is it necessary? We know from literature that low level of long saphenous vein reflux is seen in 14 to 55% of patients, but low level of SSV reflux is seen in only 3% of patients. However, we really don't know whether this reflux is of any clinical significance or not. This was a good study which was done in which thermal ablation was carried out both above the knee and below the knee. And this was a randomized controlled trial in 65 of 67 patients who were randomized. In group A, endovenous thermal ablation was done only above the knee. In group B, endovenous thermal ablation of the long saphenous was done both above the knee and below the knee. And in group C, the endovenous thermal ablation was done above the knee and foam sclerotherapy below the knee. And if you see the results, you see that at the end of follow-up, nerve injury was not seen in any single patient in those both above the knee and below the knee laser treatment. And this is because of good amount of tumescent anesthesia and good visualization of the nerves and the veins by ultrasound. The second nerve which is of importance to us is the sural nerve. And the incidence of sural nerve injury following endovenous thermal ablation has been reported in between 0 to 4.5% of patients. When sural nerve gets injured, it can cause troublesome numbness in the sensory distribution of the nerve, or it can cause significant burning and pain in the heel and the lateral aspect of the foot. Now, when the sural nerve gets injured, you will have sensory loss to the lateral aspect of the calf, the lateral part of the ankle, the foot, and even the heel. It is important for us to know the anatomical variations of the sural nerve. The sural nerve basically has 2 branches, the medial branch and the lateral branch. And the size of the medial and lateral branches can vary in different patients. What importance to note is that at the junction of the upper and the mid calf, the lower head of the gastrocnemius muscle, the sural nerve and the small saphenous vein come in close contact and run together up to the heel. And therefore, the puncture site of the small saphenous vein should be at this particular level. Apart from that, there are also variations in the termination of the short saphenous vein or the small saphenous vein, which are important. In 60% of cases, the small saphenous vein enters the popliteal vein at the popliteal fossa, either directly or after joining the gastrocnemius vein. In 1/4 of cases, the small saphenous vein ends above the popliteal fossa, either directly into the GSV through the Jancomini vein, into a perforating vein in the posterior thigh, or into the gluteal vein. And in 15% of the cases, the small saphenous vein terminates directly into a deep vein of the posterior thigh via perforating vein. Very rarely will the small saphenous vein terminate below the popliteal fossa. Now, if you see on ultrasound the relationship of the small saphenous vein and the sural nerve, at the level of the knee joint, the small saphenous vein is well seen, but you cannot see the sural nerve, it is far away. However, if you go to the level of the upper calf, you will see now you can see both the small saphenous vein and the sural nerve, and yet there is a little bit of gap between the two. However, if you go up to the level of the ankle joint, you will see both the small saphenous vein and the sural nerve are in close proximity. And here is the maximum chance of damage to the sural nerve during either cannulation of the vein or during thermal ablation. Therefore, does puncture site affect the rate of nerve injuries following endovenous laser ablation of the small saphenous vein? In patients who in whom the treatment is done by inexperienced operators who cannot adequately visualize the nerve and the vein, the chances of injury are high. However, even in experienced hands, after giving good amount of tumescent anesthesia, injury can occur. This was a good study in 60 patients with small saphenous reflux. In group 1, the axis of the small saphenous vein was along the lateral malleolar axis, so it's a very low site of puncture. And in group B, it was the mid-calf axis. And what are the results? In group 1, in which there was a low level of puncture, 2 limbs had minus paresthesia for 2 months, and 4 more limbs had some degree of paresthesia for at least a month. While in group 2, in which the puncture site was in the mid-calf, only 2 limbs had minor paresthesia for 2 weeks, which tells us once again that the higher the level of cannulation of the small saphenous vein, the better it is. The third nerve which is of importance is the tibial nerve. Now this tibial nerve has both motor and sensory components. And when this gets damaged because of thermal ablation, the patient has a difficulty in plantar flexion and cannot stand on tiptoes. And also there is loss of sensation to the sole of the foot. How can we avoid tibial nerve injury? Avoid going very near the popliteal artery and the vein. The tibial nerve and the vein lie in close proximity to them. Start thermal ablation just before the small saphenous vein dips down through the deep facial sheath. This is usually about 2.8 centimeters from the saphenopopliteal junction. If the reflux in the small saphenous vein begins in the thigh extension, then ablate this segment of the vein also. However, in such a case, limit ablation to the intrafacial portion of the thigh extension to avoid nerve injury. The next nerve is the common peroneal nerve. Again, it's the mixed nerve. It has motor and sensor components. Here, however, damage to this nerve can be catastrophic and it can give rise to almost permanent foot drop, in addition to which there is no sensation to the top of the foot. The incidence of common peroneal nerve injury has been reported to be between 2 to 4% during surgery of the small saphenous vein. The higher the termination of the small saphenous vein, the closer is the vein to the common peroneal nerve. However, no data is yet available for thermal damage to the common peroneal nerve, but in my opinion, it should be more specific. If you see here, this is the anatomy of the common peroneal nerve. It has superficial branch and the deep branch, and the common peroneal nerve is very close to the lateral fibular head. And this is the area which we must avoid either during phlebectomy or thermal ablation of any of the ways. Lastly, I'm going to discuss sciatic nerve varices. Sciatic nerve varices are very rare, and this incompetent sciatic vein appears very similar to the small saphenous vein. It's an intrafacial vein which runs lateral to the small saphenous vein in the calf, then goes deeper at the lateral popliteal fossa as it enters the deep thigh compartment to follow the course of the sciatic nerve. If by mistake we take this to be the small saphenous vein and ablate this vein thermally, there is a very good chance that we may damage the sciatic vein, which gives rise to a lot of paresthesia and dysesthesia and severe pain which can last for several months. So to conclude my talk, friends, it's important to know your nerve anatomy before doing any form of endovenous thermal ablation. Try to visualize the nerves by ultrasound before cannulation and also while doing tumescent anesthesia. The more distal the entry into the long saphenous vein and the short saphenous vein, the greater the chances of nerve injury. Use large and generous amounts of tumescent anesthesia, which will adequately separate the veins and the nerves and prevent complications. And avoid thermal damage near the fibular head. Thank you very much for your attention.